This is a PowerPoint presentation on death and dying and in nursing the end-of-life cares that we do. This quote, "I'm not afraid of dying, I just don't want to be there when it happens," by Woody Allen is a pretty good quote in relation to our societal views, generally speaking, on death and dying. In general, I would say our society has views that deal with a lot of discomfort when they're around a dying person or dying people. A lot of people don't like to discuss it openly at all. It's considered a very private manner, and they avoid discussions about death. And in general, again, our society really admires youthfulness, not aging, and of course, then certainly not dying. And we tend to have a tendency to prolong and preserve life. The first section we're going to talk about discusses loss and grief. So speaking about loss first, the definition is an actual or potential situation in which something that is valued is changed, no longer available, or gone. A few different types of loss here that we'll discuss. Maturational. Maturational is a change in the developmental process that's normally expected during a lifetime. So examples of a maturational loss would be something in which a child moves out of the house, going to college, that kind of thing, or the death of an elderly person. Could also be that an individual is no longer fertile. Situational loss is any sudden or unexpected and definable event that is not predicted. So it occurs in response to external events that are usually beyond the individual's or person's control. So examples here would be like a motor vehicle accident or a fire. And then we can have actual loss, where that's a loss that can be identified by others, versus a perceived loss where it's experienced by one individual but cannot be verified by another. Grief then is the physiological and psychological response to loss, and a few different types of grief that we'll discuss here. Normal grief is also termed in a lot of places uncomplicated grief. It's when a person has common physical, behavioral, spiritual, emotional, and social responses to death with appropriate coping mechanisms. So they have common responses and they're coping appropriately. Anticipatory grief then is where they have this pre-mourning or anticipation of the death or the loss. And this most often occurs when a family member is in hospice, because we know that there will be the loss of that person. Disenfranchised grief is when it's like an unsupported grief, so there maybe was a strained relationship and that person then feels like they cannot openly grieve. Complicated grief is also termed in a lot of places chronic grief, where it's like an unresolved or prolonged grief. And I guess the bottom line is that that person would be unable to adapt to life without the deceased person. So nursing diagnoses then that kind of go along with that complicated grief piece would be ineffective coping and chronic sorrow. So we'll talk about different manifestations of grief now, and there are quite a few. Physical manifestations, we can see neurological symptoms such as insomnia, headaches, dizziness, restlessness. We can have respiratory signs and symptoms or manifestations such as shortness of breath or tightness in their chest. Some people say that they feel like they're choking. Can have gastrointestinal signs and symptoms like loss of appetite or anorexia, GI disturbances. They could have nausea, diarrhea. They can grind their teeth, have hyperacidity or a lot of acidic secretions in their stomach. They could also have musculoskeletal physical problems such as muscle weakness or fatigue. When we look at cognitive manifestations of grief, we're talking about like the person's thought processes, and sometimes they can become very preoccupied with images or thoughts of the loss, or could even hold conversations with the deceased person. You hear people sometimes see that or say that they sense the presence of the deceased family member. People have difficulties concentrating and with decision making. You hear them complain of things like they have a decreased attention span, disbelief, confusion, forgetfulness, disorientation, or even feelings of hopelessness. With behavioral and relating manifestations, we see things like crying, sighing, them having dreams of the deceased person. They have a loss of interest in regular life events. They could have some social isolation or inability to perform activities. Just very inconsistent they could be. You hear people refer to the fact that they feel like they have this absent-minded behavior or decreased productivity, and they could be irritable. And then relating to the affective manifestations of grief, those are the feelings that you hear people say that they have, things like sorrow, fear, guilt, anger, anxiety, depression, yearning, or in some cases emancipation or relief. And a lot of times that's like if you're caring for a person that it was a lot of burden, or you could have that emancipation and relief if it was somebody who was suffering greatly. Sometimes you hear patients or people say that they have like the shock or numbness where they just feel like they don't even have any feelings at all. There can be multiple factors that would affect loss and grief. The relationship to the person, whether it be a positive or negative relationship at the time of death, and how close the person was to that person that they lost. The nature of the loss, such as was it sudden or expected, or is it a visible loss versus a private loss. And so this isn't always talking about death, but like a visible loss would be something like the loss of a limb, whereas a private loss would be something like a miscarriage. Coping strategies, so looking at their previous experience, their family support, or how does that person or family cope. Maybe they come from a very stoic family where there's no crying and they don't really share their feelings, versus a very open family. Socioeconomic status can be a factor influencing loss and grief. Tends to be the less resources a person has, the more burden a death is. Culture and ethnicity, looking at the effects on the way they express themselves during loss and grief periods and traditions that they may have, which relates into the spiritual and religious beliefs as well. Could be rituals that they have or thoughts that they have about loss and grief. And then lastly, the developmental, where we talk about the age and the stage of development. So looking at developmental considerations here, young children, when you talk about death, they tend not to comprehend the concept and they think of it more as the person is asleep and it could be reversed. With school-aged children, they understand that death is final and it's inevitable, but they believe it can be avoided, and a lot of times school-aged children will relate death with violence. Adolescents think that they're invincible and they can defy death. When they're adults, the attitude depends a lot on their cultural and religious beliefs, as well as their personal values and maybe previous experiences. As an older adult, they tend more so to accept mortality. Some have death anxiety, or they fear prolonged illnesses and dying. Death to an older adult may hold multiple meanings. This slide shows Kubler-Ross's stages of the grief cycle. You've probably heard of this process, as it's a very common process. The thing you have to think about is the length of time varies from person to person. It could be weeks in some people, years, or months or years in other people. So you can read the specific pieces on this slide, but it goes from shock and denial, which is usually up front, to a person having some feelings of anger. And they can have some depression and detachment, moving in then to dialogue and bargaining, and then acceptance. And after they accept, then they're returning more to a meaningful life after they've gone through these stages of grief. Interventions are what we as nurses can do for a grieving patient. Communication, therapeutic communication is huge. Making sure we're attentively listening to the person. Sometimes silence is the best option at that point. No advice or unwarranted assurances is the best thing. They don't want to hear advice at this point or have these assurances that everything's going to be okay and that kind of thing. They more so want you to listen to them and be present with them. Support groups would also be something you could refer a grieving patient to, as well as offering the spiritual support of their choice. So next we're going to move into more of care of the dying patient. We'll start the first slide with talking about palliative care. Palliative care is care that we provide for clients with a chronic disease that cannot be cured. So it doesn't necessarily mean that they're going to die in the next 6 months or even in the next year. It could be a chronic disease such as congestive heart failure or COPD, Alzheimer's. But the goal with palliative care then is that we're improving the quality of life for both the client as well as the family members. So it's education and support for both the client and families. One of the main goals is pain and symptom relief. So relief from the pain, relief from maybe shortness of breath or fatigue, nausea and vomiting, loss of appetite, those sorts of symptom relief so that they have the best quality of life possible. And it's a holistic look at care as well, where they pay more attention to physical, psychosocial, emotional, and spiritual needs together, not just the physical aspect of things. So then hospice care is end-of-life care, where typically most places say that the patient has to have a diagnosis of 6 months or less to live. And the emphasis is on comfort, not curing anything, but again, the symptom relief and the pain management that kind of overlapped with the palliative care, but also on the holistic approach as well, where we're looking not only at the physical relief, but also emotional, spiritual, psychosocial. So common diseases that you see patients on hospice for is cancer is probably the most common. And then the rest are other chronic illnesses such as your congestive heart failure or chronic renal failure. And it just tends to be that there's a big feeling of totally different care for the patient once they're put on hospice. And we'll watch a video in class on the hospice team to discuss that a little bit more. And I think the video will help you get a better picture of how the atmosphere just totally changes for what you're doing for the patient once they've been put on hospice. So in talking about the plan for their end of life, advanced directives can be either instructional directives or they can be durable power of attorney for healthcare. Instructional directives are when the patient's actually giving their instructions as far as what they want done in certain situations for end of life. These could be your DNRs or your do not resuscitate orders, your living wills, or IPOST. IPOST stands for Iowa Physician Orders for Scope of Treatment, and this is actually a state initiative to standardize instructional directives. We're going to talk more about and look at an IPOST in class. And then durable power of attorney for healthcare is when we're designating somebody else to give the instructions as far as what should be done. So signs and symptoms of impending death, physical signs and symptoms that we see. Patients tend to have a temperature and color change in their extremities. We hear the term mottling a lot. You see that in the picture here. Patients have decreased circulation, which means that their extremities become very cold. They have cyanosis, so they kind of turn this bluish or pale color, and then, like I said, we see this mottling that happens. They can have increased sleeping, so they're very weak and they're fatigued and they're moving around a lot less. Fluid and food decrease as well. They have this inability to swallow and a lack of appetite. Decreased urine output, so there's decreased circulation into the kidneys, and the kidneys start to shut down. They can have incontinence as well of both the bowel and the bladder as those muscles start to relax more. Congestion and gurgling is common as they have an inability to cough up different secretions very effectively, which can also cause some breathing pattern changes. They can have apnea, dyspnea, Cheyne-Stokes respirations, which we can show you a video of Cheyne-Stokes respirations, although you may have talked about that some in health assessment. And a lot of the breathing pattern changes is related to the decreased circulation to the brain. They become very disoriented because of the decreased circulation to the brain as well. They can have a lot of restlessness, again, because of that decreased circulation. Other things that we may see would be a decreased or weaker pulse, a decreased blood pressure, and then they can also have decreased activity of the gastrointestinal tract. So they could retain feces, have some abdominal distension, nausea, those sorts of signs and symptoms. We're going to do an activity in class related to different signs and symptoms that you see at the time of death and what we do to manage those in class on Monday. So different signs and symptoms of impending death related to the emotional piece. You have a really good chart in IGGI on page 112 of these emotional signs and symptoms. You can have the patient starting to withdraw. You can hear them talk about vision-like experiences. So they may see or hear something or someone that's not audible or visible to other people. This could be somebody who has passed before them. This could also be of benevolent figures such as angels. Patients also have a letting go sign and symptom where they want to hear that it's okay to go, we're all okay, or reassuring the patient and they feel like they can let go. And then of course talking about saying goodbye, and they've said goodbye to their family and those that they feel they need to. So our last section is talking about care of the deceased patient. So signs that death has occurred, absence, of course, of respirations and a heartbeat. Pupils would be fixed and dilated. They would have that absence of a pulse. So when we're saying initially the absence of respirations and a heartbeat, we're talking like about an apical pulse, but then they'd also have absence of distal extremity pulses as well. Their color turns very pale or pallor. Their body temperature drops. They could have that release of stool and urine after they've passed. Eyes may remain open, but typically the jaw also falls open, and sometimes what catches people off guard is you still can hear fluids trickling through like the intestines internally. So how we confirm death in a hospice setting, it can just be one hospice nurse that actually confirms death. Typically in an acute care setting, usually you have to have two different nurses pronounce death, so you would need to know your hospital's policies in relation to that. But normally how you confirm death is by listening to the apical pulse for a full minute, and you're listening over all four valves of the heart to confirm that there is no heartbeat. Also listening for the absence of respirations via a stethoscope, and then you're verifying that fixation of their pupils and that lack of reaction of their pupils. So then changes that occur in the body after death, we refer to the first as rigor mortis, and that's the stiffening of the body that you've probably all heard about, that typically occurs about 2 to 4 hours after death. Typically you start seeing it first in any small muscles, like more so the jaw and the neck, and then it starts moving into the larger muscle groups, like your extremities. And so nursing implication wise, it's just important to position the body, have the body in the position that they're going to want it to be in, and closing the patient's eyes and their mouth, putting dentures in before rigor mortis would set in. Algor mortis then is the gradual decrease in the patient's body temperature and the skin loses elasticity too as that body temperature goes away. And so you really have to think about, with algor mortis nursing wise, that the skin can be easily torn. So as you're moving the patient and that kind of thing, you want to be very cautious of that. Pallor mortis is that pale color of the skin due to no circulation, but then you can also see livor mortis, where you have discoloration of lower or dependent areas of the body due to blood pooling, and you can kind of see both the pallor mortis and the livor mortis in the picture here, where the blood has pooled greatly. You see the darker discolorations, and where it's pale, that's the pallor mortis due to no circulation to that area. That's clearly where pressure was, and so you're not having the blood pool there where the direct pressure was on that person. So on Monday in class we'll be doing activities related to the end-of-life cares and different application exercises to kind of put this all into play. Thank you.